What I'm going to try and do in this talk is to weave surgical pathology and cytopathology into a single talk, which I realize in retrospect is a bit of a challenge because trying to address both of these audiences is somewhat of a challenge. But nevertheless, if you think of it, cytopathology is so closely aligned to surgical pathology, more so in the pancreas than any other organ I can think of, which makes this talk somewhat worth its investment in time and effort. So virtually every month, we sit down together, the gastroenterologists, the surgeons, the radiologists, and the pathologists sit down together in a room, and we go over cases that have been operated in the last month or so, and then also go over cases that are being considered for surgery. And it's been an amazing learning tool. And the one message I want to leave you with is, I think when you're dealing with pancreatic cytopathology or you're dealing with histopathology, this more so with cytopathology, this is a truly multidisciplinary effort, and it is not appropriate to work in a total clinical vacuum. So I thought in about 45 minutes or so, all I could do is to focus on one topic. I chose to focus on intraductal papillary mucinous neoplasms. I'll call them IPMNs. This is by far and away the most common cystic neoplasm that we see in our clinical practice, and I assume you as well. So let's start with some basics of cytopathology. For the surgical pathologists in the room, just bear with me. So whether it be a biopsy that's performed or whether it be a fine needle aspiration, both of these approaches are through either the duodenum when you're dealing with the pancreatic head, or the body when you're dealing with the pancreatic body and tail. So what the endoscopist does is there's a EUS guided needle that's put into the pancreas to obtain a fine needle aspirate or a biopsy. And this becomes important because as those needles go through either the stomach or the duodenum, they carry some of that surface epithelium with them. Unfortunately, quite a bit of surface epithelium. That is what we refer to as GI contamination, and that is probably the leading cause of a false positive diagnosis on an EUS guided aspirate from the pancreas. GI contamination can be quite cellular. Believe it or not, all of this is contamination from the stomach. GI contamination comes in two flavors. One is gastric. This is gastric. This is probably an aspirate either to the body or the tail of the pancreas. And you can see these very flat monolayers, very benign appearing cells. But here's the problem with GI contamination. Now, the most common intraductal papillary mucinous neoplasm is lined by gastric epithelium. And so the question is, how do you tell between gastric epithelium, low-grade gastric epithelium from an IPMN, from low-grade normal gastric epithelium from the stomach? And the reality is it's virtually impossible to tell the difference between the two. And duodenal contamination is sometimes even more challenging because it appears dark and three-layered and hyperchromatic. There are two things that help you with duodenal contamination. One is seen here. These are goblet cells. This is the so-called starry sky pattern. And the other thing that's helpful is that if you see a flat monolayer, you'll often see these sesame seeds on top of the epithelium. These are intraepithelial lymphocytes, which are seldom seen with an IPMN. But what about this sort of a layer? It isn't quite organized. It's a bit disorganized. There's a lot of overlapping going on here. Is this GI contamination? It probably is. But here's the bottom line, and here's my solution to that problem. GI contamination could be essentially indistinguishable from IPMN, and my solution to that is to label all benign appearing monolayers as GI contamination. Now that will increase my specificity of my diagnosis. What I do not want is false positive diagnoses. The reality is that cytology is only one component. Molecular testing, particularly if you do NGS testing, is a far more specific and sensitive means of establishing a diagnosis, and we'll talk about that in a minute. You could also get contaminating mucin from the surface of the GI tract, and so how do you tell the difference between mucin that comes from an IPMN and GI contamination. At times you simply cannot, but mucin from an IPMN tends to be more abundant, tends to have that wall-to-wall mucin, and two, it tends to have this rather lamellated structure like seen here. So the one thing to remember when you're looking at these biopsies or these cyst fluids from pancreatic cysts is to remember that you are not alone. These are the 4 pillars that will help you, and always look for them. The management of IPMNs has been codified based on those 5 pillars, including cytopathology, and this is the most recent set of guidelines. This is the Fukuoka guidelines. And you might ask yourselves, why do we need these complex guidelines, and why do I need to know this? All right, I'll give me a minute and I'll tell you why. If you are 70 years or older, if you are, that's still young according to me, 40% of you will bear a pancreatic cyst. And I know that most of you are not too keen on undergoing pancreatic surgery. So there is some good news as well. The good news is that most of these pancreatic cysts are benign. The overwhelming majority are benign. The other thing not to be forgotten, even in this day and age, is that pancreatic surgery is still associated with significant morbidity and mortality. The mortality is still about 1%. And remember, perhaps not you, but the majority of patients have a fair number of comorbid conditions. So we're not racing out there to resect all these pancreata. So you got to be very careful about who you resect and who you leave behind. And you do want to resect the more aggressive ones because that's your only chance of curing these patients. So we try and resect only the ones at the highest risk of progression or those with cancer. So Karen Pinto, I and Ranjan Chetty, Ranjan is from Canada, are trying to put together this textbook that should be in the shelves by the end of this year, which essentially tries to cover both cytopathology and surgical pathology, somewhat like I'm doing in this talk. But we've tried to simplify things. We've simplified those guidelines into cartoons. This is one by Karen Pinto that I'll be using in my talk. This is in your handout. Feel free to print it and put it on your wall. Just make sure you give Karen her due credit. So what is our role as cytopathologist, if you are one? Our role is to preoperatively decide when to, we don't make the decision. We help the surgeon guide his or her hand to decide whether to resect or observe. To make a diagnosis when possible. I say that because in many instances we may not be able to make a definitive diagnosis. There are some instances where we make a perfectly good diagnosis. But with the advent of next-gen sequencing, I think this part of the equation is perhaps a little less important than this part of the equation, identifying advanced cysts. By that I mean cysts with high-grade dysplasia or invasive adenocarcinoma. And we do that by identifying what we refer to as high-grade atypical epithelial cells. So let's very briefly talk about imaging. I'm not planning to make radiologists out of you. This pattern, the macrocystic pattern, is often seen in a branch duct IPMN. This pattern, a cyst with a solid component or a mural nodule, when seen, is very concerning for malignancy in an IPMN, an invasive process or high-grade dysplasia. This unilocular pattern is seldom seen in an IPMN. This pattern with a central scar is almost never seen. This in an IPMN. This is classic for a serous cystadenoma. Let's talk very briefly about chemical analysis of pancreatic cyst fluid, or PCF for short. IPMNs and mucinous cystic neoplasms. When I use the word neoplastic mucinous cyst, I refer to both of these lesions together, typically show an elevated CEA when compared to its mimics such as serous cystadenoma. In fact, if you see a CEA of greater than 800, it is virtually diagnostic of an IPMN. Greater than 200 is highly suggestive of an IPMN. If you see a very low CEA, you're probably not dealing with an IPMN. Molecular has now become the 800-pound gorilla in the room. It has completely changed our approach to the analysis of pancreatic cyst fluid. It is exquisitely sensitive and fairly specific as well. Now, each each one of these common cysts of the pancreas are associated with unique mutations. Let's distill that out into a single table. Essentially, it's as simple as this. If you see KRAS and or GNAS mutations, you're very likely dealing with an IPMN. If you identify P53 or SMAD4 mutations, you're probably dealing with an advanced cyst. And I'm going to turn to you, the surgical pathologists in the room, because sometimes you're all high and mighty because you have so much tissue more to work with. If you ever see a resection with those mutations, these mutations that I'm referring to, you need to redouble your effort at identifying high-grade dysplasia and invasive carcinoma and stop pointing fingers at your cytopathologist. Cytopathology of the pancreas is hugely challenging. And finally, when you see VHL mutations, that is near diagnostic of a serous cystadenoma. So this fluid, obviously, you get a couple of cc's of fluid. You can imagine is extremely precious, and which is why right up front, we send material for molecular analysis at our lab, because I think it has a bigger influence on making a diagnosis in some ways than pancreatic cyst cytopathology. But I would not pit them against one another. Essentially, cytopathology has some advantages, and so do molecular analysis, and each of those are associated with their potential downsides as well. And we'll talk a little bit about. So I thought I'd use this case to illustrate a few things. If you go back to the history, this is a youngish male with abdominal pain and jaundice. Ding, ding. Remember the jaundice. Here's the imaging, and this is the pancreas, and you can see a massively dilated main pancreatic duct. That is by definition an IPMN. There's very little else this could be. Let's look at the algorithm. Remember, this is the modified Fukuoka guidelines that Karen put together. Let's look at obstructive jaundice, main pancreatic duct dilatation. Yes, ding, ding, consider a resection. And so the reality is that this patient does require a resection. Let's try the European guidelines. Absolute indications for IPMN resection, dilated main pancreatic duct. We're done. And the reason for that is that almost half of these patients with a main duct IPMN have an invasive adenocarcinoma. So there's really no need of a pre-op diagnosis. Nevertheless, somebody decided to stick a needle into this and identify it as, you remember this image, abundant mucin. Notice this sort of folded paper-like appearance here. Remember, you don't have to see cells. The mere presence of abundant mucin like this is diagnostic for a neoplastic mucinous cyst. In this context, an intraductal papillary mucinous neoplasm. The cytopathologist will be thrilled to see this image, and so am I. Notice this sort of drunken honeycomb appearance, pale voluminous cytoplasm, irregular nuclear contours. This is adenocarcinoma. So there's absolutely no need to beat around the bush. We can call this adenocarcinoma. Now, there's a caveat that I do want you to put in there, and that is invasion cannot be excluded on a fine needle aspiration biopsy. And that's become important because a significant proportion of patients are now treated with neoadjuvant therapy. So remind your clinicians that a diagnosis on cytopathology of adenocarcinoma is not invasion. You do not want to be treating these patients with upfront chemoradiation. So here's the resection. Here's the pancreas. The pancreas has been filleted open, and it's filled with this very fleshy matter. It looks rather glistening. This is very classic for a main duct IPMN. Here's the resection. This is the main pancreatic duct. Notice this papillary mucinous epithelium. These are the branches with very similar papillary mucinous epithelium. When you look at these pancreata, the first thing you'll be struck with is the complete loss of pancreatic acinar tissue. And that's because when the duct is blocked, all of the acinar tissue essentially dies away to be replaced by fibrosis. When you look at IPMMs on very low power, the first thing you'll notice, they have rather round to oval profiles. And that's because these are dilated ducts. Now, if you see irregular profiles, you should seriously consider the possibility of an invasive carcinoma. So go high and take a look at those foci that aren't quite oval or rounded. those oval rounded sort of bulgy profiles. So now we are in a duct. You can see this papillary epithelium, very high grade. There's no question this is high grade dysplasia. Notice the loss of mucin. This does look very pancreatobiliary, sort of columnar to cuboidal squat cells. This is the so-called pancreatobiliary type IPM, and we'll talk about that in a minute. But take a look at this focus. There's glands here. I give it to you that this does look lobulated, but look at that nerve there. This is perineural invasion. That's very, well, that is cancer, isn't it? And as you go on higher power, you'll get more and more concerned by these areas, these small glands with very high-grade nuclear atypia. So this was actually an invasive carcinoma with limited invasion, although I would not put that in the report. We do not make diagnoses like microinvasive carcinoma or early cancer. Instead, what we do is we stage it like you would stage a pancreatic ductal adenocarcinoma. This measured about 0.5 centimeters, and therefore this is PT1A. Now, this patient will very likely do well, but any focus of invasion significantly increases your risk of dying from this disease. And this is exactly the reason why we, the pancreatic pathology, will insist on putting the entire cyst through, even if it means 300 sections. Because you would never have found that focus if you hadn't put it all through. In fact, some people advocate putting the entire pancreas through. I may not go that far. All right, let's look at one more case. This patient is slightly older than the one I just showed you. Here's the cyst on cross-sectional imaging. It looks like a bunch of grapes. That's pretty typical for a branch duct IPMN. In fact, on the MRCP, there was a direct communication between the main pancreatic duct and the cyst, which is essentially diagnostic for a branch duct IPMN. Now, these lesions are not necessarily as easy as this on imaging. I'm just showing you examples that were very, very classic. So this is definitely a branch duct IPMN on imaging. The cytology was much more subtle. A little bit of mucin as seen here, but not enough to feel all warm and fuzzy and go out and call it an IPMN. It's certainly consistent with that radiology impression. But what is more interesting on the cytology were the clusters of cells. There weren't very many of these sort of three-dimensional clusters with community borders and irregular nuclear membranes and high nuclear cytoplasmic ratios. This is what we refer to as high-grade atypical epithelial cells. So let's take a step back and ask, how does one make a diagnosis of an intraductal papillary mucinous neoplasm, or broadly a neoplastic mucinous cyst? I almost like to think of it as a two-step process. Step one is establishing a diagnosis of an IPMN. And in my book, step two is probably far more important, and that is grading of the neoplastic cyst, because it is that grading that's going to decide who stays, which cyst stays and which cyst comes out, right? So that's a big deal for the patient. So let's talk about step one, the diagnosis of an IPMN. Imaging is a pretty good approach, as we saw in this case. Cytology, as in this case, was helpful, but not all that helpful, as is often the case in these IPMNs. You tend to see mucin in just over half the cases, and in the other half of the cases, there just isn't enough mucin to make a definitive diagnosis of an IPMN. Cyst fluid CEA is perhaps a more sensitive and specific means of establishing a diagnosis of an IPMN than cytology, but it has its limitations. Molecular analysis, particularly KRAS, GNAS, and RNF43, is now the 800-pound gorilla in the room. Now, I do not have a precise number on this, but molecular analysis is more sensitive for diagnosis of IPMN than cytology, although they work very nicely in combination. Let's talk about step two, which is grading these IPMNs. Remember, this is the more important part of the whole process. Radiology, cytology is actually pretty good, and so is imaging, and that combination is extremely powerful. Chemical analysis does not help, and molecular analysis in this context is somewhat helpful, but is quite imperfect. So these mutations suggest an advanced neoplastic cyst, but this is neither sensitive nor specific enough to act on these mutations if seen in isolation. So back to the 75-year-old guy, the imaging was very suggestive of an IPMN, so we didn't really need any other modalities to identify an IPMN. Interestingly enough, the cytology was very suggestive of an advanced neoplastic cyst, suggesting that regardless of what this is, this needs to come out. And molecular analysis had identified a p53 mutation, which is very consistent with what we found the cytology findings of those high-grade atypical cells. What I did not mention here is this: there was also a KRAS mutation. So it all leads to an advanced intraductal papillary mucinous neoplasm, and even though he's 75-year-old, he deserves a pancreatic resection. So clearly these high-grade atypical epithelial cells in these cyst fluids make a huge difference. What we are looking for is these high-grade clusters of atypical cells with or without necrosis, and they can be very subtle, and this is a challenging area of cytopathology. I think this is one of the most challenging areas of cytopathology. One is because these samples are extremely cellular, not like you surgical pathologists who have the whole pancreas to work with and all your 300 sections. Two, remember, these cells have been floating around in fluid, and so they've been sitting there, God knows, for weeks and months, and so they're not very well preserved, as in this set of cluster of cells. And then finally is this nightmare scenario, right? Remember, the needle goes through here. Imagine a gastric ulcer going through this the needle going through this gastric ulcer, and imagine them picking up these cells right here. Now, the surgical pathologist in the room will have a hard enough time identifying these cells, and imagine the plight of the poor cytopathologist. So when I typically do this, I show several examples of pancreatic cysts on cytopathology. Unfortunately, I'm not going to be able to do that, but I'm going to show you this case, 73-year-old with a cyst that was suspected to be an IPMN. He has abundant mucin that is diagnostic of an intraductal papillary mucinous neoplasm. Notice this sort of very stringy appearance. There's a cluster of cells, and then there was an isolated cluster of cells that looked like this. High nuclear to cytoplasmic ratios, well preserved, nice abnormalities in the nuclear envelope, and some parachromatin clearing. These are high-grade atypical epithelial cells, and this on resection turned out to be an invasive adenocarcinoma. Of course, they're not as easy as that. Many cases are extremely challenging. But the message I want to leave you with is do not ignore these small atypical epithelial cell clusters, particularly these three-dimensional clusters, and the necrosis here is concerning for an advanced pancreatic cyst as well. So it's time to talk about the histology of IPMN. Let's start by talking about the definition of an IPMN, and let's break it down. So an IPMN is dilatation of the pancreatic ductal system, the main or the branch, that is then lined by, it's dilated because there's mucin, and the lining epithelium is mucinous epithelium. Typically, what I've forgotten here is papillary. So just for the sake of argument, this is the branching pancreatic ductal system. This is what happens in an IPMN. The ductal system is dilated, filled with papillary mucinous epithelium, bulging with abundant mucin. Of course, we don't see cases in 3 dimension, at least not yet. Maybe there'll be a day we'll start signing out cases in 3 dimensions, but we see everything in 2 dimension, and your section would probably be across somewhere like this, and this is what you'll actually see under the microscope cysts. Now, obviously this is a ductal system, therefore they're round, and that becomes important because things that are round are probably not invasive. Things that are irregular, you really do have to be concerned that you're dealing with an invasive adenocarcinoma. But the reality is when you look down the microscope, it looks somewhat different, right? Obviously, you can't really get a cartoon to quite show all of these variations. But you can see that most of these cysts are round, but you can see that the epithelium also extends into the lobules themselves. Here's a lobule involved by IPMN, and so therefore that low power appearance is somewhat more complex than the cartoon I drew. So IPMN, by definition, we'll talk about this in a minute, must measure greater than 1 centimeter, and then I'll let you read that. In fact, I'll let you take this home with you, put it on your wall, but give Karen Pinto credit when you do. There are 3 types of IPMN, and you can muck this, you can muck that, you can muck that other thing, but I particularly don't find mucks particularly useful. I do my I do my distinction between these three types of IPMNs based on the histologic appearance. So what helps in making the diagnosis of an IPMN? The first thing I think you must remember that it's very helpful is taking a look at the growths yourself. Here's a classic main duct IPMN. Notice this villus proliferation growing into an IPM, into the lumen. There's no question that this is an IPMN. You don't even need a microscope to do that. What you need to have a microscope for is to identify invasion. And so unfortunately, you got to put the whole pancreas through. So here's the good news for you surgical pathologists. You should put the did I say whole pancreas? No, I misspoke. I meant the whole cyst through. But if you want to put the whole pancreas through, it's not such a bad idea. So these specimens could end up being 200 sections and more. So they're a lot of fun to work with. This is a more typical branch duct IPMN. It's sort of a series of sacs all close together. It's very unlikely that this is invasive because there is no mural nodule. So the gross appearance of an IPMN is very characteristic, very different from all its other mimics. That's a serous cystadenoma. Very different. What I thought I'd do is to talk a little bit about the things that you must address on your report, right? Or must you? So we'll talk about that. Invasion, no question about that. That's a big deal. And that's because the moment it's invasive, that puts the patient at a significant risk of dying from this disease. So let's use this case as an example. Now, here's an IPMN. I'm telling you that. You can see big dilated ducts here, right? And they look sort of round to oval, so I'm not really suspecting invasion. There is papillary mucinous epithelium. Here you go. Often they have this very edematous cores in them. And this epithelium, you'll agree with me, looks awfully gastric, right? This is gastric foveola-type epithelium with these apical cups of mucin. These look like pyloric glands. In fact, when you look at these gastric type IPMNs, they really do recreate the gastric antrum. Now, this is obviously low-grade dysplasia with basal nuclei, but there were areas with high-grade dysplasia, and what I'm really worried about is these glands. See them sort of wandering away from the cyst. That is very concerning. And when you look at these under high power, you'll see these sort of angulated glands with what looks like desmoplastic stroma, although you got to be careful. It's sometimes hard to tell between what's desmoplastic stroma and what is just fibrosis from chronic pancreatitis. But you'll agree with me, this is cancer. So this is an invasive adenocarcinoma. Limited invasion. We do not use the word microinvasion. The behavior is largely determined by the T stage, and we often see these patients with multiple foci of invasion. And one of the questions that is asked is, how do you measure the size of the tumor? Do you add it up, or do you take the size of the largest tumor? I think most people use the size of the largest tumor, but that answer is a bit up in the air right now. So invasive or not, absolutely, you must have that report, and you must put that whole damn, pardon my French, cyst through to make sure that there is no invasion. Grading of the intraductal or intraepithelial process. Remember, we moved from a 3-grading system of low, intermediate, and high. We moved to low and high. Low and intermediate is low, and high is high, and that's how we decided to mix things up. So if you want to call something high grade, it's got to look really bad before you call something high grade. The question is, do you absolutely need it? Let's talk about that. So this is low grade, right? I don't think, and this is gastric type intraductal papillary mucinous neoplasm. Notice frequently the gastric types have this very myxoid stroma. This is low grade, right? If you want to call this intermediate grade, that's fine, but remember, intermediate grade is low grade. Remember that, look at the nuclei, they're very basally placed, so very nice polarity, low nuclear cytoplasmic ratios. So this is definitely low grade. This is prototypic high grade. I love finding these clusters, these detached clusters of cells floating off in the lumen, this micropapillary architecture, high nuclear cytoplasmic ratios. This is high grade dysplasia. So it's obviously important to get it into that report because your cytopathologist, for sure, if there's been an FNA, would be interested if they call it high, if their high grade call was correct. But how much of that is needed in terms of grading? How much of that is needed for patient management? And the reality is it's not going to change patient management. That, of course, does not mean that you don't put it up there. So my reports will certainly identify invasion if there is. They'll grade the intraductal component. The third thing that you're asked to do is the histologic type. Remember, there are three histologic types. There's gastric, there's intestinal, and there's pancreatobiliary. Remember, the oncocytic subtype was initially part of IPMN, and now it has its own cubbyhole. It's its own entity, or the IOPN that we'll talk about in a minute. So I thought I'll show you one example. This is an intestinal type IPMN. Notice these large dilated cysts. They look sort of roundish, certainly look papillary. There's a lot of mucin up there. And notice all the mucin here. Typically, intestinal type IPMNs are associated with a thick and very, very viscid mucin. And on high power, you see this papillary appearance, again, this sort of lamellated mucin that is so typical of an IPMN. And if you look at intestinal type IPMNs, the first reaction is it looks like a tubular villus adenoma of the intestine with all those goblet cells. And that's really what it is. If you look down the microscope, if it looks like gastric epithelium, it's gastric epithelium, and I wouldn't go about doing muck stains. If it looks like a tubular adenoma, it's an intestinal type IPMN. By definition, all intestinal type IPMNs are high grade. So gastric, intestinal, and pancreatobiliary. Typically, pancreatobiliary have very little mucin and have these quad cuboidal to columnar cells. Although some people believe that a lot of what we classify as pancreatobiliary type IPMN is really high-grade gastric type IPMN, but that's a story for another day. So this classification does certainly have some prognostic relevance, but does it really change management? And the answer is no, although your surgeon will certainly be looking for it. And finally, must you, in your report, define main duct versus branch duct, or what is referred to as a mixed type, which is main and branch duct. Now, this is very important before surgery. This is what the radiologist does, right? We don't have any part to play there. If it's a main duct or a mixed IPMN, those go to surgery for the most part. Well, the management for branch duct really varies, and we have guidelines to address that issue. But this is not really required post-operatively. If you think of it, the deed is done. If you must do this, if you do want to put main duct versus branch duct versus combined main and branch duct in your report, I'd suggest you base it on a gross evaluation. Mere microscopic involvement of the main pancreatic duct is not sufficient. Microscopic involvement by mucinous epithelium of the main pancreatic duct is simply not sufficient to make this distinction. So, issues that you must address are invasion. Absolutely. You've got to put, whether you like it or not, that entire cyst through. Grade and type, yes, it has some minor influence, but it definitely does not change management. And main versus branch, it's up to you, between you and your surgeon, but I'd suggest you do it on the gross evaluation. All right, so now let's talk about the differential diagnosis of an IPMN. And this is again in your handout. It's a lovely cartoon figure, or what is referred to by the younger folks as infograms produced by Karen Pinto. Again, you're welcome to put these on your wall and distribute them, but do give Karen credit for these. All right, so here's a duct, right? Lined by foveolar type epithelium. Is this an IPMN? The answer is no. This is pancreatic intraepithelial neoplasia, low-grade pancreatic intraepithelial neoplasia. So how do you tell the difference between PANN and IPMN? Because all PANNs, or virtually all PANNs, and a significant proportion of IPMNs are lined by that low-grade gastric type epithelium. right? So this is an IPMN. We saw this earlier in the presentation. It's lined by low-grade foveolar epithelium. So how do you tell the difference between the two? In general, IPMNs are larger, right? So this is an IPMN because it's large. This is a very low power. And they also tend to be very papillary. But the reality is you've got to define these in some fashion. And the way the WHO has defined them is entirely based on size. This is a bit odd, isn't it, to arbitrarily divide two entities simply based on size, but there you have it. You've got to have some rules. And this sort of makes sense, right? Because you don't want to be calling tiny lesions in the pancreas that are simply not detectable on imaging IPMNs. On the other hand, if a surgeon takes out a sizable lesion from the pancreas, you don't want to be calling that a pannin, right? That's not going to make the surgeon happy. That's not going to make the patient happy. And ultimately, that's not going to make you happy. So here are our rules. So if it's more than 1 centimeter, it's IPMN. If it's less than 0.5 centimeters with pannin, and you're probably asking yourselves, what happened to that stuff in between these two measurements, right? And we have a term for that. We call them incipient IPMNs. I didn't make this up. This is the WHO recommendation. I assume what they're thinking of is that these are probably IPMNs, but we are not quite willing to call them IPMNs. All right, so by definition, we talked about IPMNs as dilatation of the ductal system lined by mucinous epithelium and almost always having these papillary processes. So here's the question. What if you have a cyst that measures more than 1 centimeter, so it's not pannin, lined by low-grade mucinous epithelium, but no papillary processes? And we have a name for that, and that is simple mucinous cyst. So this is what a simple mucinous cyst looks like. What is interesting about them, before I forget, is that they seem to be slightly genetically different from IPMNs. So perhaps they are their own entity and we aren't making something up. But here's what a simple mucinous cyst looks like. When you look at this under here's pancreas back there. When you look at this under very low power, you see this sort of pseudocapsule, and you invariably see a single layer of lining epithelium. And that lining epithelium is mucinous, although in areas you can see it's got flattened and cuboidal. Most importantly, so this is very low grade. Occasionally people have described higher grade atypia. The most important thing to remember is that there is no ovarian type stroma. If there is ovarian type stroma, that is a mucinous cystic neoplasm. So here's another example, partly lined by what looks like low-grade foveolar type epithelium, no ovarian type stroma, but the other part was lined by this low cuboidal nondescript sort of epithelium. So this is a simple mucinous cyst. All right, so let's keep going. Differential diagnosis of an IPMN. Take a look at this. You probably have an answer, right? This is a mucinous cystic neoplasm. Mucinous cystic neoplasms, if you haven't heard this already, are defined not by the epithelium. It's really fascinating that mucinous cystic neoplasms can be lined by epithelium that are almost entirely non-mucinous, this nondescript sort of cuboidal lining epithelium. Mucinous cystic neoplasms are defined by the presence of this very plump stroma that looks essentially like the ovary and stains like the ovary. So it's relatively easy to tell the difference between an IPMN and a mucinous cystic neoplasm. The only thing is, like with an IPMN, with a mucinous cystic neoplasm, you might have to put you do have to put the entire cyst through to rule out invasion, but the ovarian stroma may be very focal. It's often very focal when you have significant high-grade dysplasia, particularly with invasive carcinoma. But in the low-grade components, you will see ovarian-type stroma. This, of course, is a tumor that has a very unique demographic. Middle-aged to elderly women in the tail of the pancreas. You almost never see this in men, although a couple of weeks ago, I did have an example in a man, so they have been described. All right, so we're still talking about the differential diagnosis of an IPMN. This is a retention cyst. So we haven't quite worked out what a retention cyst implies. But the theory is this, that the ducts get blocked and you have backstream dilatation of the ductal system causing a large cyst. What is interesting is people have actually identified mutations in this lining epithelium, but that's a story for another day. So how do you distinguish between a retention cyst and IPMN? Retention cysts by and large are lined by this nondescript cuboidal epithelium. They lack ovarian type stroma. They're typically small and incidental, although occasionally they tend to be large, and they are typically seen downstream of a neoplasm, right? So there's obstruction proximally and downstream dilatation. Rarely with a retention cyst, and this is where the differential diagnosis of an IPMN comes in, rarely you will see mucinous epithelium like seen here, but it should not be diffuse. So this is a retention cyst. Finally, pseudocyst, right? By definition, a pseudocyst should not have any lining epithelium. And here is the lack of lining epithelium. In theory, you've got to put, well, I'll rephrase that. In practice, if a surgeon sends you a pseudocyst, and we don't see them very commonly these days, but you've got to again put that entire cyst through to rule out lining epithelium and to rule out ovarian type stroma. But there's a couple of things that will help you diagnose a pseudocyst. One is, most often there is evidence of chronic pancreatitis, significant chronic pancreatitis in the background. That's one. Two, often these people present with acute pancreatitis. Doesn't mean to say that everyone who presents with acute pancreatitis has a pseudocyst. IPMNs can certainly present with acute pancreatitis. And so often the surgeon would be pretty confident that they're dealing with a pseudocyst because the clinical story is very, very typical. So pseudocyst will lack lining epithelium. All right, continuing with the differential diagnosis of an IPMN. Now, I told you that an IPMN is dilatation of the ductal system lined by mucinous epithelium within the lumen. Now, you certainly can have other neoplasms that grow within the ductal system. Generally, these neoplasms do not show very much mucin, although they could focally show mucin. So the first of these entities is referred to as an intraductal tubulopapillary neoplasm. At one time, these used to be mistaken for IPMNs. These are genetically very different from IPMNs, but like IPMNs, they can progress to invasion. But let's see how to tell the difference between an IPMN and an ITPN. So here's the duct, massively dilated duct. Here's the background pancreas, and you can see an intraductal proliferation. When you look at ITPNs under very high power, intraductal tubulopapillary neoplasms on high power, the first thing you'll notice is the lack of mucin. So that should tip you off that you're probably not dealing with an IPMN, although the pancreatobiliary type IPMNs tend to show very little mucin as well, and that could be an issue. But they typically, unlike the pancreatobiliary type IPMNs, ITPNs have this sort of acinar architecture that is very, very, these tight little acinar structures all back to back, and that's a very classic architectural pattern for an ITPN. Now there is another entity that used to be classified as a IPMN, but is no longer classified as an IPMN. In fact, this entity has been taken out of the category, completely out of the category of IPMNs, and given a distinct cubbyhole of its own. And this is referred to as an intraductal oncocytic papillary neoplasm, or IOPN. And that was justified because they, one, behave very differently. So IOPNs have a very different behavior. Let's get it out of the way. They actually do very, very well. So even when invasive, this is one of those neoplasms that does very, very well. So long-term survival in spite of invasion. And two, they're genetically very distinct. This was beautifully put together by two groups recently, a significant proportion of these have FGFR2 fusion, so they're genetically very different. But nevertheless, like IPMNs, they have a very intraductal pattern of growth. But the cytology of these cells is very interesting and very unique. Abundant eosinophilic cytoplasm and big prominent nucleoli. And I'm going to please the cytopathologists in the audience. And here's a cytopathological evaluation of one of these IOPNs. And you see these distinct cell membranes, abundant granular cytoplasm. This is a Papanicolau stain, and characteristically these big prominent nucleoli. So if you can't make up your mind, you could try a fusion assay. And finally, one final intraductal process that is not an IPM. Now, this is a duct that's massively dilated. You can see this is again in the pancreas, massive atrophy in the background pancreas. This is extending into the branches of the pancreatic duct. This looks a little like an ITPN, doesn't it? It certainly doesn't look like an IPMN. It doesn't have mucin. In fact, there was no mucin whatsoever. Instead, it has this rather granular pink cytoplasm with these big prominent nucleoli. This is an intraductal acinar cell carcinoma. And so for whatever reason, some acinar cell carcinomas decide to stay within the ductal system, and these are referred to as intraductal acinar cell carcinoma. The closest differential diagnosis in this instance is not an IPMN, but actually an ITPN. And this tumor, as you can see, you do need immunostains to make this diagnosis, was diffusely and strongly for trypsin, as seen in this image. This is an intraductal acinar cell carcinomas. When intraductal, these seem to do fairly well. It's when they're invasive that they behave badly. And with that, that's a roundup of intraductal papillary proliferations that could potentially mimic an IPMN. Thank you.